Our next session is on recurrent acute pancreatitis. May we invite the moderator and chairpersons to the stage. Dr. Vikas Singla, Senior Consultant, Max Hospital, Delhi. Dr. G.K. Dali, Professor, IPGMR, Kolkata. And Dr. Mani Maran, Professor, Gastroenterology, Stanley Medical College.
Good afternoon. At the outset, I thank the organizers who inviting me as a chairperson for this wonderful conference. Special thanks to Dr. Sudipto for his personal invite. Dr. Piramanayagam does not require any introduction to this audience. However, he did his MBBS in Kilpauk Medical College and MD in AIIMS Delhi and DM Gastroenterology in SGPJ Lucknow. He has many publications in his name. Everything is published in national and international journals. He teaches endo-ultrasound, many of us. I still remember he hold my hand, teaches me endo-ultrasound. Advanced teaches Davis as Professor. If you listen the Pramos talk, he is very clear in his concept, very simple in his language, and very depth in his subject. Eagerly waiting to listen his talk on quantitative imaging at EUS for diagnosis of early chronic pancreatitis. Over to Dr. Piramanayagam.
Good afternoon to all. Thank you, Dr. Mani Maran, for all your kind words. I hope to do justice to what you have told me. So I thank Dr. Sudipto and the organizers for inviting me over for this wonderful conference. So the brief for me for this next 15 minutes is to speak about quantitative imaging at EUS for diagnosis of early chronic pancreatitis. So I'll go through this in the following headings. We'll look at what is the current criteria that we use, the morphological criteria that we use to diagnose chronic pancreatitis, what is its limitations, and what is the definition for early chronic pancreatitis. Do we have a standard definition, or is there still some lacunae in that? And what does quantitative EUS imaging add to this, and where does it stand in the current date? And do identifying this early, so-called early chronic pancreatitis really matter in follow-up? So the current sensitivity, I mean, apart from EUS, we always rely on easier imaging techniques like ultrasound, CT, and MR. If you look at the sensitivity of ultrasound, CT, and MR with these criteria to pick up early chronic pancreatitis, the sensitivity is only about 60 to 70%, not very ideal. So an ERCP always, we don't do that as a diagnostic test. It's mainly only when we have a therapeutic potential. So we're looking only at ultrasound, CT, and MRCP for picking up these early changes. The sensitivity is about only 70%. So far from what we would like it to be. EUS has long been used to identify patients who present to us with recurrent abdominal pancreatic type of pain and whether it could be an early chronic pancreatitis. So if we use the standard B mode criteria, there are two sets of criteria that is in use. One is the standard criteria, other is the Rosemont criteria. The standard criteria is we have about 9 criteria, that is about 4 in the parenchymal criteria and 5 ductal criteria. And if we use 4 out of 9, we will call it as possible chronic pancreatitis. And this has been compared with histopathology in multiple studies. What we see is that depending on the number of criteria that we use, the sensitivity also seems to vary from 60 to 90%. And the correlation with the number of criteria and the fibrosis doesn't seem to be good across studies. Some say it's good, some is poor. So moving on to a row that paved the way for another objective way of defining this chronic pancreatitis by a Rosemont criteria. Again, this is a B mode criteria where they had some major and minor criteria. And with that, they gave different stages, like consistent with chronic pancreatitis, whether these criteria are suggestive of chronic pancreatitis or indeterminate for chronic pancreatitis, or this findings normal. So they used as different subsets of how good or how confident are we of diagnosing this as chronic pancreatitis. When they compared with histopathology with 50 patients, we find that about 96% of the patients who had Rosemont criteria, which is suggestive of chronic pancreatitis, actually had early chronic pancreatitis. But what is important to know is that 50% of patients who had a normal study, when we say normal on Rosemont criteria, still had chronic pancreatitis on histology. So we are missing out those when we restrict ourselves only to B mode imaging. So therein we needed something better on EUS to see if we can identify or we can perform better in identifying early chronic pancreatitis. But what exactly is early chronic pancreatitis? How do we define that? In 2018, there was a consensus which they tried to come up with a definitive diagnostic or a definition for early chronic pancreatitis among major pancreatic associations, but they failed to give a consensus statement that could be developed for the same. What they did understand is that you can't diagnose the early chronic pancreatitis based only on imaging or morphology. You need to have a setting, that is risk factors. You need to have the clinical features. You need to have the imaging modalities which would pick it up. Also functional testing, and if possible, an histological evaluation. So it has to be an amalgam of things to diagnose early chronic pancreatitis. So the closest that could come to was the Japanese criteria, where the Japanese Pancreatic Society, initially they gave a criteria in 2009-15, and then they revised it in 2019, where they have a mix of both clinical and functional features and in imaging findings. The clinical features could be any of the 6, where they have recurrent abdominal pain, abnormal urine or enzyme levels of lipase, abnormal exocrine function, or person who are predisposed to this, who have continuous heavy drinking or pancreatitis-associated gene mutation, or patients who have a previous history of acute pancreatitis. So that sets the clinical picture. And with imaging findings, there was initially a list of 7 findings on B-mode imaging that they have restricted now to just 4, or it could be some changes in the ERCP. So a mix of either of these was used, and they defined early CP as those who have imaging findings with the early CP, and functional and clinical, 2 of the functional and clinical features. So that gives us a working diagnosis for early chronic pancreatitis, for definition for early chronic pancreatitis. Now coming to the main focus of this talk, which is about quantitative EUS imaging in diagnosing early chronic pancreatitis. The premise is that as the chronic pancreatitis progresses, we expect more fibrosis to set in, and fibrosis in the tissue makes it more stiff. So stiffness is assessed by elastography. It could be qualitative or quantitative, though my talk will be more towards how we evaluate it quantitatively, and it is by elastography. But before all this elastography came in, the earliest attempt at quantifying this fibrosis was on the B-mode imaging by using some computerized statistical software, was to look at the size of the hyperechoic area, which was above threshold level, and they could see that when they compared it with the standard EUS criteria, with increasing severity of chronic pancreatitis, the size of that hyperechoic area was also increasing. So that was the earliest attempt before the elastography set in. So what is quantitative EUS elastography? We have 2 modes of looking at it. One is the strain elastography, other is a shear wave elastography. Most of the current machines that we use a strain elastography. What is strain elastography? Here the stress is produced by repeated either manual compression or by allowing the physiological contraction from the nearby blood vessels, the heart or the respiration, to provide the stress to the tissue. And you look at the mean lesion deformation. So how stiff, that would depend how much the lesion deforms. So that could be measured by either a strain ratio, or it can have a bar histogram and analyze that to give us an approximate quantification for this. But the problem with this was that there was a good amount of inter-observer variability. On the other hand, shear wave elastography, that is what we generally, it is very widely used in liver. We have enough, fibroscan everywhere. So there you have a focused ultrasound beam that is sent from the transducer into the tissue, and the velocity with which the waves move can be calculated, and that can be represented either as velocity, or it could be proportional to the stiffness, which can be expressed as a kilopascal. This is highly reproducible. So most of us at present, or have whatever machines we have, uses a strain elastography pattern. Here, this is more often studied with mass lesions for the pancreas, less for chronic pancreatitis. So there is relatively less data, but we'll go through that in the next few minutes. So it could be qualitative or it could be quantitative, and you use this in it could give a color code map with the hardest tissue being blue and the softest being red. Or as I told you, it could measure it with a strain ratio or a bar histogram. Here you can see that there's a bar histogram which tells us more about it. So in the strain ratio, we look at, this gives you a qualitative image with the blue and green images, where you can always measure the strain deformation in the area of interest and compare it to the area of adjacent normal tissue, and that will give you a parameter. And the histogram is at one place where you can definitely measure in multiple settings, and you will get a bar histogram. Again, the mean of it is taken into consideration. So they did compare the strain ratio with the standard B-mode Rosemont criteria, and they found that the strain ratio cutoff of more than 2.25 could identify early chronic pancreatitis with a very good area under curve. They also noted that when we use the strain ratio, they found that it increased from a normal to a chronic pancreatitis to a much more higher strain ratio for a pancreatic malignancy. And they also correlated, I think one of the previous speakers did come to this talk, and they said that there's a compared with the EUS strain ratio and an endoscopic pancreatic function test, they found that there's a linear correlation between the EUS strain ratio and the peak bicarbonate secretion. So the higher EUS strain ratio means that there's early chronic pancreatitis, as I said, seems to correlate with a poor exocrine function as well. And when they did a multimodal evaluation where they looked at abnormal strain ratio along with endoscopic pancreatic function test, and it seems to correlate well as well. So apart from the strain ratio, there are also certain data, certain studies which are used at the bar histogram mean value, and that also seems to correlate with the Rosemont criteria, where you can find that as the Rosemont criteria worsens, the mean value seems to come down. There's an inverse correlation between these two. And they did compare with histological fibrosis on surgical specimen, and that also seems to show that the grade of fibrosis correlated with the EUS quantification based on bar histogram analysis. So coming to the second way of monitoring, which is this, of studying this quantification, is the shear wave elastography. Herein, instead of looking or waiting for the compression to be given by the transducer or by the pulsations, here the transducer itself will emit a wave, pulse wave, which will travel through the area of interest, and the reflection with which it comes can be measured. So that is the principle by which it works, and we are all familiar with the FibroScan, where it has been extensively used and studied in the liver. But the limitation for this is that there is limited processors which are available. At least from 2019, there's been particularly it is restricted to the Arieta 850 system, which has a probe and the software which goes with it. So it is yet to be standardized for chronic pancreatitis. Here, what we measure would be the shear wave velocity, and that could be correlated with the stiffness with which it comes. So in the area of interest, you might find that the velocity with which it moves can either be monitored, or it could be translated into the stiffness of the organ. So the area of interest should be less than 2 centimeters from the transducer, and it ideally should be less than 1.5 to 1 centimeter in cross section. So that would be the way it looks. And again, this shear wave elastography has also been compared to the B-Mode-Rosemont criteria, and the shear wave velocity was higher in the early chronic pancreatitis group. When they compared a shear wave elastography to a strain elastography, there has been a single study which has come up, and it shows that the shear wave elastography performs better in identifying early chronic pancreatitis. But all this is good, but does it really matter? Are you able to, does it really translate into important clinical practice? Is there a progression when we when we identify patients early? This is a 2-year follow-up study published from Japan, where they had 23 so-called early chronic pancreatitis diagnosed as per Japanese criteria. Only about 5% progressed to definite chronic pancreatitis in the next 2 years, and about 1/3 actually improved. So not that when we identify something on EUS doesn't always mean that they are going to progress to a chronic pancreatitis. Another experience from UK, where they found 40 minimal change chronic pancreatitis based on clinical and EUS features. When they followed up for 2.5 years, they found that about 1/3 progressed to definite chronic pancreatitis, where about 10% actually regressed. So imaging doesn't always mean, imaging diagnosis of early chronic pancreatitis doesn't always mean that they will develop the chronic pancreatitis. This was an interesting study that they looked at EUS and the secretin-based endoscopic pancreatic function test, where they could use both of this to predict the progression to definite chronic pancreatitis. Only in this median follow-up of, this is the longest study that you have, median follow-up of 7 years, they found that 21% progressed to definite chronic pancreatitis, and the main predictors were a peak bicarbonate, that is on endoscopic pancreatic function test, if the bicarbonate secretion is less than 80 milliequivalents at baseline, or a Rosemont criteria suggestive of CP at baseline, and about 1/5 if they have progressed to definite CP. So to summarize, early chronic pancreatitis is still a definition which is still in evolution. We don't have a clear-cut diagnostic criteria, but the basic what definition right now is what has been offered by the Japanese Pancreatic Society. B-mode EUS criteria is quite subjective, so it is limited specificity. So there's been a lot of interest in identifying pancreatic fibrosis by elastography. We do it by two ways, strain elastography and a shear wave elastography. Shear wave elastography is much more reproducible, but limited availability as of now in India. We need more data. But we also need to remember that this quantitative EUS has good correlation with pancreatic function test, the B mode criteria, and the pathology as well. But it also serves us to remember that whatever we identify as early chronic pancreatitis may sometimes be a little overdiagnosis, because as we see, only about 10 to 15% actually progress to a established chronic pancreatitis in the next 5 to 7 years. With that, I thank you for your patient hearing. I'll be happy to take questions.